Aesthetic crown lengthening, part 3, compound crown lengthening. Compound crown lengthening is removal of facial gingiva and buccal bone. And you will remember from the second video where we talked about simple crown lengthening, which was just removal of facial gingiva, unattached gingiva. The first case we're going to show is simple crown lengthening in the maxillary anterior with compound crown lengthening in the posterior. The diagnosis on this young lady is she does have gingival asymmetry between the central incisors. Second, she has a very introverted personality because these 16 and 17-year-old girls think that they have baby teeth and they purse their lips in such a manner that they really have a very introverted personality and they suppress their smile. Finally, obviously she has a gummy smile, and if you look in the posterior, there's a lack of depth. It almost looks like she's a dentulous in the posterior area. And in the posterior area, these teeth have been treated orthodontically and have been intruded, so the buccal bone is very, very thick. But look here how short these premolars are. They're only about 4 or 5 millimeters long, and they should be 9. Now in the maxillary anterior, you will note that the incisal edges are not even. One of the things that you should do is to go ahead and do an enamelplasty on those incisors so that you measure from the same place. To view this enamelplasty technique, please click on the annotation or link the video description on YouTube. So this is after we have elevated the flap before we've done the osseous surgery, and we will actually go into the technique on how to do that in the next case. You'll notice the sutures are a double suture, and you can see how much we have crown lengthened and how much enamel we've exposed. Those sutures, you can view the inbound-outbound suturing technique, which is part of the video on the coronal position flap, by clicking on this annotation or by using the link on the video description on YouTube. So here it is sutured, and here it is preoperatively, and this is postoperatively, and you will note from the annotation here how much enamel has been exposed. So facial bone was removed, but no interdental bone, and although that embrasure space is open, that papilla will recur because it's only 5 millimeters from the contact point, as we have pointed out here by Dr. Tarnow in his classic article in 1992. Because if that distance is 5 millimeters, 98% of that is going to come back. Now, the key number, as we pointed out, when the crest of the bone is 5 millimeters or less from the contact point, the papilla fills the embrasure space 98% of the time. Now let's talk about the importance of the incisal edge. You will note here that tooth number 9 is a little longer than tooth number 8. So ideally, we should go in there and even those by enamelplasty to get the same level of incisal edge so that when we make our measurements, we won't build into a discrepancy in the apical area. This is a case that I learned that on, but did not do it until later in the treatment. So as we look at that, this is our free gingival groove. You will note on number 8, we have 9 millimeters of tooth showing, and 11 on number 9, where we have it higher on the distal facial, so that's going to be our guideline that we are going to crown lengthen to. So we went in, and you will notice that I have crown lengthening on number 8, although I have not done the enamelplasty. I simply viewed 8 and 9 and went ahead and with the radiosurgery removed enough tissue where the tissue is higher on the distal facial than on the mesial, trying to match up the same appearance. But now here's what's interesting. I could have done the same thing here because look at the amount of free gingiva we have. That's an ideal indication for a simple crown lengthening. However, Dr. Tarnow's article, which was published in 1992, we're now about 1996, and I decided to test his hypothesis. So what I did, I went ahead and flapped the tissue, removed the interdental tissue, but you will notice that from the crest of the bone to the contact point is 5 millimeters. And Tarnow says that that papilla will come back. Now let me tell you what, that was gutsy on my part on about a 16 or 17-year-old girl in 1996. So here it is the day of surgery, and you will note the black triangle. I was very anxious to see her, and when she returned in 6 weeks, look how much this papilla had come back. So this case, in my opinion, proves that Tarnow's conclusions in 1992 were correct. Now we see the final case, and you will see the tissue matches pretty well on both central incisors, and you will note that I have done the enamelplasty, which I should have done preoperatively. Now let's look at the in-depth technique. This is a dental student, and you can see how she postures her lips not to show the gum, and she is somewhat introverted, but we see when she smiles broadly how much gingiva is going to need to be removed. This case is a compliment of Dr. Brian Mantor, who practices in Las Vegas, Nevada. He did this as a student. We're doing the bone sounding here with the periodontal probe. Here again, we're demonstrating Ocean Beam's roll technique to see how much attached gingiva that we have, and you can see on the right the abundance of keratinized tissue. So Dr. Mantor went in there and made his scalloped incisions, and when he reflected it, look at the osseous defects that were going to need to be removed. What I would like for you to see now is that after the crown lengthening was done, it was somewhat underdone on tooth number 8, and we're going to follow that through. So here we see the bone level on number 8 is a little thicker and not quite as much was removed. By using Dr. Stephen Chew's crown lengthening gauge, we can avoid that mistake. So here we see the final osseous surgery, and remember, when the contact point is 5 millimeters or less from the crest of the bone, Tarnow has told us the soft tissue fills the embrasure space 90% of the time, and you will see that Dr. Mantor did leave the 5 millimeters there. So here we see the suturing, and this is the way the case looked post-operatively. So this is where we started, and this is how it looked post-operatively, and a very nice aesthetic result. Congratulations, Dr. Mantor. Now, this is an interesting case. We notice the gingival asymmetry between number 8 and number 9, and this patient was a rugby player, and he fractured off the incisal edge of this tooth, and the orthodontist elected to smooth that edge up and then extrude the tooth to match up the incisal edge. In retrospect, this was a mistake because the tooth should have been restored. But in any event, now that the tooth has been extruded, what do we know? First of all, it was slowly extruded, which means that the bone on the facial of that is very thin. So therefore, we're going to do a modified technique on this. And after going in and doing the radiosurgery, as you will notice on the right, we are right down to the sulcus, and if we stop here, that's totally going to rebound and look like the slide on the left. But what we did was make an incision from the mesial facial line angle to the distal facial line angle, and then took a curette and curetted off bone 3 millimeters from the margin to get the ideal gingival margin to bone relationship. And here we can see the little bit of bone that was taken out. And that, as I said earlier, the tissue level is 3 millimeters from the crest of the bone, which is ideal. 3 weeks post-op, you will notice that the crown lengthening has been successful. The tissue is the same level on both incisors, but what I want you to note is the difference in the biotype between the centrals. It's normal to thin on the number 9, but on number 8, we have a thick biotype, and we've severed the attachment, and I guarantee you we're going to get some rebound. So now let's look at the tooth 4 years post-op. You'll notice there's a little chip here where the patient continued to play rugby and fractured the tooth again, but we can see the amount of rebound that has taken place on number 8 because we did sever the attachment. It's only 9.5 millimeters long compared with 11 millimeters on the other central. But the amount of aesthetic improvement was satisfactory to the patient. So here we see where we started, and now we see the difference 4 years later. Although the tooth is shorter, the gingival contour is better on number 9, and the patient is very satisfied with the aesthetics. And remember, we discussed earlier, what is aesthetics? What the patient thinks is aesthetic, not what we think. Now, crown lengthening to enhance restorative. Again, this case was treated in private practice by Dr. Brian Mantor in Las Vegas, Nevada. You will notice how short these teeth are from wear, so a stent was made on a model after a wax-up, and then this suck-down stent was made to determine where the incisal edges were going to be after the teeth are restored. But first, we need to do some crown lengthening. Because the length of the tooth is only 5 millimeters, and we want it to be 11, so the prosthodontist on this case ultimately is going to add 6 millimeters. So here the incisions have been made, and the osseous surgery is being done, as well as on the lower. And we can notice now that the tissue is higher on the distal facial of number 8 versus number 9, so Dr. Mantor has really progressed in the years since he's graduated from his residency. And the lower we see here, and now the areas are sutured together, and post-operatively on the left we can see the patient is now ready to have the restorative done, but note the wear. Here is the final post-op, one of the nicest cases I've seen in a long time, and you will notice the night guard that was placed here. Obviously, with that amount of wear, you're certainly going to want to have a night guard made. This is where he started, this is where he ended up, and Brian Mantor, you did a great job, as well as the prosthodontist, Dr. Marco Padilla. Hopefully now we have shown the second way of doing crown lengthening, and the final video will be on complex crown lengthening, where we remove facial gingiva, facial bone, as well as interdental bone.